Good morning, and thanks for stopping by my poster. My name is Jonathan Bleeker, one of the medical oncologists at Sanford Health in Sioux Falls, and I want to take a moment to give you an update on a trial in progress that we are running at Sanford sites both in Sioux Falls and Fargo, being funded by a DaCCoTA pilot grant. The title of the project is Investigating the Utility of Circulating Tumor DNA in Predicting Outcomes Following Definitive Multimodality Therapy for Locally Advanced Esophageal and Gastroesophageal Junction Cancer. To give you some background, esophageal and GE junction cancers are cancers we see regularly here in the clinic. Standard management strategies for these locally advanced cancers include chemoradiation followed by surgery. And recently there has been evidence to suggest that the addition of immunotherapy following surgery improves outcomes. There is still much to be done to improve outcomes for these patients, as long-term data would suggest that less of half of patients are actually cured with this therapy, and there has been much work to identify biomarkers in an effort to select the patients best suited for certain therapies and make sure that we are not over or under treating patients. One of the big questions is whether surgery actually improves outcomes, as there is conflicting data on this. As I said, biomarkers are felt to be very important. We need better biomarkers to identify who may benefit from what can be a very morbid procedure. One of the biomarkers that has emerged in the world of cancer over the past 3 to 5 years is circulating tumor DNA. This has been shown in multiple different cancer types to be prognostic, help predict the risk of recurrence, help predict the outcomes following treatment as well. Esophageal and GE junction cancers have not been as fully investigated as some other subtypes in terms of how ctDNA may help improve outcomes, and we're hoping to help build the case that ctDNA does have a place in this particular tumor type. So the schema, as outlined in the poster, we're going to take 20 patients at both Sanford Health sites and get paired genomic testing, both from tissue from the esophagus and circulating tumor DNA prior to any intervention, then utilize chemoradiation as treatment, followed by surgery with serial blood samples to investigate ctDNA throughout those various treatment time points. Our aims, number one, is to try to identify how much concordance there is between a tissue sample and a ctDNA sample. How much do they agree? How reliable is ctDNA in this particular disease? Because we know that in various disease types it can be more or less reliable. Secondly, to help investigate how serial ctDNA values may help predict outcomes. Is it possible, for instance, that down the road we could say a patient who has a negative ctDNA following chemoradiation may not need to go through a morbid surgery? Or a patient who has positive ctDNA findings after surgery may need more therapy. That's the longer term goal of what we're hoping to achieve with this kind of a project. This is a pilot to prove that's a feasible question to ask in this setting. And then specific aim 3 is really to ask the question, how does ctDNA correlate with clinical features, subtypes in terms of pathology, tumor grades, tumor stages, response to therapy, et cetera, to help, as I said, build the case that this may be a helpful tool going forward. Our goal is 20 patients. We have 11 consented, 8 of which are completely through their course of therapy, and we have 7 samples currently being processed for that paired tumor ctDNA genomic evaluation. Enrollment has been a bit slower than hoped, a number of reasons for that, including COVID, but we are still optimistic that by the end of August 2022, we will have all 20 patients enrolled, and I look forward to coming back to this group and reporting the results of this project. Thank you for your time. Thank you to DaCCoTA for the funding and for stopping by our poster.